Hello, and welcome to another edition of Orthopedic Sports Medicine Patient Educational Series with Dr. Adam Derhake. In this video, we're going to explore some of the issues that involve the long head of the biceps tendon as it attaches within your shoulder. This video will explore the different types of pathology that we see involving the long head of the biceps tendon, some of the pain and symptoms that can result from that pathology, as well as your different treatment options when addressing the long head of the biceps tendon surgically. Specifically, we're going to explore the difference between a biceps tenotomy versus a tenodesis, and which specific indications are more appropriate for each type of treatment. After fully exploring and understanding your treatment options of the long head of the biceps, patients can make the most appropriate decision for their specific situation. In order to fully understand the different types of pathology that we see regarding the long head of the biceps tendon, as well as the different treatment options, it's essential to first understand the anatomy of the biceps muscle, as well as both the long and short head of the biceps. Because of that, let's take a closer look at the anatomy of the shoulder and the biceps and how that anatomy helps us to determine both the pathology of the biceps as well as the different treatment options. Okay, so let's look at the anatomy of the shoulder and specifically the anatomy of the long head of the biceps and how this anatomy plays into our decision-making process when deciding how to treat symptoms related to the biceps tendon. So this is a right shoulder, this is the arm, here is the shoulder blade, here is your collarbone in the front, and the arm goes up into the ball and socket joint. And the biceps, of course, is the muscle that extends down into your arm. The biceps, bi means two, like bicycle has two wheels. The bicep muscle actually has two tendons, one that comes up around the top of the ball and attaches onto the top of the socket inside the ball and socket joint, and the other one that attaches over here outside the shoulder joint. This tendon of the biceps is called the short head of the biceps tendon, whereas the tendon that attaches inside the ball and socket is called the long head of the biceps tendon. And it is really the long head of the biceps tendon that can contribute to pain or symptoms within your shoulder. Although you can have isolated pathology of the tendon, oftentimes biceps pathology is associated with other injuries of the shoulder, such as a rotator cuff tear. The first type of pathology that we see of the long head of the biceps is simply tearing of the long head of the biceps. Most of the time that tearing occurs inside the ball and socket joint. So in other words, it occurs in the portion of the tendon once it leaves the arm and goes up into the ball and socket where it attaches onto the top of the socket inside the ball and socket. This tearing on occasion, however, can extend down and into what we call the groove of the biceps, and if the biceps pathology extends further down, then this can dictate the different types of treatment options that we offer to patients. The second form of biceps pathology that we commonly see is called subluxation of the long head of the biceps tendon. This is almost always associated with a tear of your subscapularis tendon, which is the tendon of the rotator cuff that attaches into the front of the ball and socket. If we fold back the subscap tendon, we see that the subscap tendon is attached on this bump in the front of the shoulder called the lesser tuberosity. If the tendon tears away from this bone, then the biceps is no longer contained within the groove and it'll jump out of the groove, and we call this maltracking, or subluxation of the long head of the biceps. That can be a source of clicking or catching or popping in the shoulder, as well as pain. If this is the case, then the biceps tendon again would have to be addressed surgically. The third type of pathology that we see of the long head of the biceps deals specifically with where the biceps attaches onto the socket inside the ball and socket joint. So what we're going to do is I'm going to remove the arm so we can look specifically at the socket of the ball and socket joint. When we remove the arm, we see the long head of the biceps, which comes up around the top of the ball and curves around to attach over on the other side of the joint on the socket. Oftentimes, if you have problems with where the biceps attaches, the biceps tendon itself can be free of any significant tearing. However, if we look specifically at the socket of the ball and socket joint, around the socket is a rim of cartilage called the labrum. And specifically, the labrum up at the top of the socket is where the long head of the biceps attaches. This is called your superior labrum. And patients can have tearing of their superior labrum. If the labrum up at the top of the socket tears, then every time you pull on your biceps tendon, it's going to place traction on this torn labrum, and that can result in significant pain or symptoms within the shoulder. If at the time of your shoulder arthroscopy we find that you have an unstable superior labral tear, oftentimes we will elect to perform either a biceps tenotomy or a biceps tenodesis in order to address pain or symptoms related to the labrum. So let's talk about the two primary surgical ways that we address pathology of the long head of the biceps tendon. The first way that we address biceps pathology is called a biceps tenotomy procedure, where we simply cut or remove the biceps attachment over on the socket and allow the biceps to retract down and out of the shoulder joint. The reason that we are able to perform a biceps tenotomy is again because the biceps has two tendons. One is the long head, which attaches inside the ball and socket, and the other is the short head that attaches over here outside the ball and socket joint. So by releasing the long head of the biceps tendon, the short head of the biceps is still attached and will compensate. And so therefore patients lose very little in terms of strength or function in the biceps following a biceps tenotomy procedure. The second way to address biceps pathology is with a biceps tenodesis procedure. In this case, we also go in and cut or remove the attachment of the biceps over on the top of the socket. However, after we release the tendon, we then drill a hole up at the top of the biceps groove, where we then reattach the long head of the biceps with a screw, so that now the biceps tendon is pulling from the top of the groove as opposed to pulling over at the top of the socket. On occasion, we may find that the pathology of the biceps extends down and into the groove. If that is the case, then performing an arthroscopic biceps tenodesis at the top of the groove could potentially leave sources of pain or symptoms down into the arm. Because of that, on rare occasion, intraoperatively, we do elect to proceed with an open subpectoralis biceps tenodesis. What that means is instead of reattaching the biceps up here at the top of the groove, we will make an incision down here in the armpit and access the biceps further down the shaft of your arm and reattach the biceps here as opposed to up there. And because of that, this significantly diminishes the risk for continued or recurrent biceps pain postoperatively. So let's first talk about a biceps tenotomy procedure. With the tenotomy procedure, you are simply performing a release of the tendon where it attaches on the top of the socket, allowing the tendon then to retract out of the shoulder joint. The advantages of performing a tenotomy is that I have never had any patient have any residual pain related to their biceps tendon as a result of a biceps tenotomy. There's no longer any tension on the tendon. So if there is disease along the tendon, partial tearing of either the tendon or the labrum where the tendon attaches, all of those problems are alleviated with the tenotomy. This includes patients that have disease of the tendon that extends down into the arm out of the shoulder joint. Because a biceps tenotomy addresses any and all pathologies of the biceps tendon, I have found that the tenotomy procedure is much more reliable in terms of producing a pain-free shoulder. There are, however, two potential things that can develop as a result of biceps tenotomy that patients should be aware of. Number one, when the tendon is released and it retracts down into the arm, you can often end up with a bump in the biceps muscle called a Popeye deformity. This is a bump within the bicep muscle that actually makes the muscle look a little bigger or asymmetrical from the side that was operated on versus the other side. This is a cosmetic deformity only, and unless I really point it out to patients, it may not even be that noticeable. A Popeye deformity is much more noticeable in patients with a smaller circumference of their arm. As the arm gets larger and larger, the deformity that's produced as a result of a biceps tenotomy becomes less and less obvious. The second result of a biceps tenotomy that can occur that should at least be discussed with patients is the possibility of developing biceps cramping in the muscle. After release of the bicep tendon, if you return to very heavy lifting activities, during heavy exertional activities of the bicep, you can develop some cramping within the bicep muscle. This feels like a tightness or a discomfort or pain with heavy lifting. This process is a temporary process, and as time goes on, we would expect that the patient would experience less and less biceps cramping. However, in my younger patients or in my laborers, or anyone that wants to be lifting an excessive amount of weight with their arm following the procedure, I do try to avoid a biceps tenotomy because of the associated biceps cramping that can occur with heavy lifting. For most of my older retired individuals, however, I usually don't even give them the option of a biceps tenodesis, as the grand majority of those patients do exceedingly well with a biceps tenotomy. In general, patients can expect only an 11% decrease in strength of the bicep muscle following a biceps tenotomy procedure. For most patients that aren't involved in heavy labor activity, this diminished strength is barely noticeable on a day-to-day basis. In fact, very little of my biceps tenotomy patients even recognize that there's a difference in the function at all. Oftentimes, patients can naturally rupture the long head of the biceps tendon, and after the initial pain, swelling, and bruising go away, they realize that all of the symptoms that they may have had in their shoulder prior to a spontaneous rupture have now resolved, and they haven't really noticed any difference in terms of the strength or function of their arm. Now let's talk about a tenodesis of the long head of the biceps tendon. With a tenodesis, we are still cutting or removing the attachment of the long head of the biceps from the socket. However, instead of just allowing that tendon to retract down and out of the shoulder joint, we are now going to reattach the tendon over on the top of the ball. This is a procedure that's done arthroscopically within the joint. For more information regarding the specifics of the surgical steps required to perform a biceps tenodesis, please refer to my video on the surgical procedure regarding a biceps tenodesis. There are a number of differences in the postoperative rehabilitation after a tenodesis versus a tenotomy. With the tenotomy procedure, because we simply release the tendon, there is absolutely no restrictions on the biceps or the arm following the tenotomy procedure. Of course, if the tenotomy is performed in conjunction with other procedures such as a rotator cuff repair, you will have restrictions related to that other procedure. With the tenodesis, in contrast, we have now reattached the tendon over on the top of the ball. And so we need to get that tendon to heal back down to the ball before we can start using the biceps muscle. Because of that, following a biceps tenodesis, we have no active range of motion of your elbow or of your biceps for the first 6 weeks following the procedure while that tendon is growing back into the bone. This means that you will be in a sling with no use of that biceps for the first month following the procedure. You do come out of this sling and do some passive range of motion exercises of your elbow, meaning that you actually drive the elbow with your other arm in order to flex and extend it. This is to prevent the elbow from getting stiff following the procedure. However, you are not doing any active range of motion exercises with the elbow. In other words, you are not independently, without help, moving the elbow into flexion, as this job is primarily performed by the bicep muscle, and we don't want to be pulling or placing tension on your previous tenodesis site. One of the disadvantages of a biceps tenodesis is that it is possible that you could have continued disease or pathology of the long head of the biceps that continues down into the arm. This can be an area of the long end of the biceps that we cannot completely visualize at the time of the operation. Because of that, on occasion, we do find that patients continue to have biceps-related pain following their tenodesis because of more distal disease or disease further down into the arm. When going into any shoulder procedure, if a tenodesis of the biceps is required because of significant tearing or disease, then my preference is try to tenodese the biceps arthroscopically at the top of the ball. This is much more minimally invasive and is done with the scope. However, we are always prepared intraoperatively to convert to an open subpectoralis biceps tenodesis further down into the arm if absolutely necessary because of unforeseen pathology of the biceps that extended out of the shoulder into the arm. Whether you have a tenodesis up at the top of the ball or a tenodesis further down the arm, the restrictions in the rehab following the tenodesis are identical. The primary function of the biceps muscle is not only to perform active flexion of the elbow, but also supination of the forearm, which means rotating the forearm in a clockwise direction on the right hand. This is particularly important with opening doorknobs or turning screwdrivers with your right hand. Because of that, patients with biceps problems can have more symptoms on their dominant right arm than on their left arm, because we live in a right-handed world when it comes to doorknobs and screwdrivers. Because of the difference in the way the biceps functions between your right and left hand, my recommendation as to whether or not to perform a tenotomy versus a tenodesis can vary based on which shoulder is involved. I hope this video has helped you to better understand the difference in the treatment options between a biceps tenotomy versus a tenodesis, and which patient populations or indications would be more appropriate for each case. After being fully informed about the treatment options available for your specific types of biceps pathology, I know that you can make the appropriate decision that's best for you. I hope you've enjoyed this video. Have a good day.